Okay, before we go to the comparison, you know, this is the last, diffusion was the last lecture of the semester, so the theme there is random walk. I think it's a very fitting theme because normally this course is done literally on the last Friday of the semester. For most of you, the last formal undergraduate lecture you hear, so I hope that for your master thesis you won't make totally random decisions. Your direction might be quite random, and of course, as we all know, life will have for sure some random components. So that's the theme. So now we'll start comparing the different imaging modalities. First, let's look at contrast and limitations. Contrast mechanisms. So we'll look at what the modalities that we have looked at in the course and the major limitations. Computed tomography, that's the first imaging modality that was introduced. The contrast mechanism, there's two essentially. It's largely electron density, but also the atomic number Z comes into play with the photoelectric effect. Yet the major limitation of X-ray imaging is that it is pretty much limited to contrast between bone and tissue and air and tissue. So what one needs is strong electron density differences. So the source of contrast, that is here, what the contrast mechanism is, has a strong implication on the limitation of the imaging modality, and as we shall see, that's a recurring theme. Another limitation, of course, is ionizing radiation. One cannot use everything that one wants to use. Then we had emission computed tomography or single photon emission computed tomography and the related technique, positron emission computed tomography. The contrast mechanism there is the distribution of radio tracer in the tissue. That's the contrast. You have more of the substance in the particular voxel or less of it. That will affect the intensity of the pixel in the image. Limitation for SPECT is the choice of gamma emitters that are available who emit the X-rays in a suitable window that one can detect. And another limitation is that these techniques typically have non-uniform spatial resolution and sensitivity. For positron emission tomography, I subsumed that under gamma emitters, of course, there the modality is limited to nuclei that are positron emitters. So, magnetic resonance, a very limited contrast mechanism is spin concentration, or as we've dealt with this in the course, the density of water in the tissue, but it's limited. The major contrast mechanism is relaxation. We've dealt with T1, T2, T2 star. Another contrast mechanism is the separation of fat and water through the chemical shift. So it's a chemical contrast. One can differentiate whether a pixel, the intensity in a pixel, the signal corresponds to water or fat. That gives another ability to separate. We have seen today the effect of diffusion on the signal. That's also a contrast mechanism in magnetic resonance. We have seen also flow. I didn't list it here. I just put etc. because there are a plethora of different contrast mechanisms that one can measure with magnetic resonance. They have different degrees of importance, and we don't really have time in this course to cover them all. The major limitation of magnetic resonance is sensitivity. It's very low sensitivity. So one cannot talk about tracers. One has to look at highly concentrated molecules like water. as a result of the way the image is acquired, MRI is typically time-consuming and motion-sensitive, therefore. Take, for example, a CT scan. On a modern CT scanner, it takes a couple of seconds to do pretty much a whole body scan. If you do that with MRI, you're in there for minutes. There's not much choice there. And a limitation is, it is a complex methodology. Now think about X-ray imaging. You turn on the X-ray tube, the camera, the source rotates around the subject, you obtain the image, it's reconstructed. With magnetic resonance imaging, you have so many ways, if you choose the wrong parameters, to generate an image that has no contrast or even no signal. So it is a complex methodology and requires quite some sophistication in its management. But you can see it is also the technique with the most different contrast mechanisms that can contribute to contrast in the image. And the last technique I want to list here, that's the first one we talked about, that was ultrasound. And the contrast mechanism there is the boundaries of tissues with different mechanical properties or acoustic impedance. The limitation is exactly this boundary between tissues with different mechanical properties. The extreme case is bone and tissue. So bone is the ultrasound signal does not penetrate bone, so it is not the preferred imaging modality, for example, for the brain, because there is a skull around our brains. There might be some species where this might not be the case. So that's the recurring theme. Most of the contrast mechanisms, most advantages in the imaging techniques also define their limitations. Okay, now let's compare a bit sensitivity, signal-to-noise ratio, and the reconstruction methods. How can one maximize the sensitivity, that is, the signal-to-noise ratio of a technique? In computed tomography, how can we maximize the signal-to-noise ratio? So if you remember, in computed tomography, what one measures is the number of photons removed by the tissue. So if one wants to increase the signal-to-noise ratio, one has to just blast the tissue with more photons. So conclusion here, increase the radiation dose. Just turn on the current in the X-ray tube, gives you more electrons, gives you more photons with which the tissue is irradiated, and that gives you better statistics. That increases the signal-to-noise ratio. What about SPECT and PET? What does one do there to increase the signal-to-noise ratio? So there we measure molecules that have a radio tracer, an X-ray emitting nucleus. So what is the simplest thing to do? We inject more emitting molecules, more positron emitters for PET, more gamma emitters for SPECT. So that means one increases the tracer dose. There's a caveat here, which we haven't talked about. There is a limit up to which you increase the signal-to-noise ratio. After a certain point, it starts to drop again. And that has to do with the number of random events that are being detected in the PET scanner, for example. Or at some point, the counter is just overwhelmed with the number of X-ray photons that are being detected. But in principle, one can increase the SNR by increasing the tracer dose. Magnetic resonance. How can one increase the signal-to-noise ratio? Remember, the signal-to-noise ratio is proportional to the thermodynamic equilibrium magnetization. And that depends on gyromagnetic ratio. That one cannot change. Depends on the temperature. Well, most of our subjects are at around 310 Kelvin. So we can't really change the temperature either. And the third factor that influences the equilibrium magnetization is the static magnetic field. So increase the magnetic field. Buy magnets with stronger magnetic field for MRI. More expensive magnets, that's a consequence here. But just to give you an idea, 30 years ago, it was thought it was impossible to do imaging at magnetic field strengths above 1.5 Tesla. 35 years ago, there was even a debate whether one could even image at 1.5 Tesla. Then 1.5 Tesla became in the clinic the standard of care, was the high-end magnetic field for magnetic resonance imaging for diagnostic purposes. And this is now increasingly being replaced by 3 Tesla, twice the magnetic field strength. And of course, there will be the question in a few years whether this will be replaced by 7 Tesla. What are the limitations? Well, to increase the SNR in computed tomography, one is limited by safety concerns. At some point, one will just create radiation damage. We have seen one example in the course for an angiogram from a subject. The tracer dose, actually PET and SPECT, they have relatively low radiation dose, so I could increase them, but at some point one is going to get a lot of scatter noise and a lot of random noise in the counts. So that means that the detector no longer properly counts the photons and is discarding too many, and then the sensitivity is being reduced again. And the sensitivity limitation for magnetic resonance imaging, I already mentioned it, that's just a Boltzmann distribution for the equilibrium magnetization. If one can play with that and can manipulate that, then one can increase the sensitivity. There are some limited techniques that are currently being experimentally tried out on some molecules to circumvent that. But for all intents and purposes, for the imaging as we've dealt with in this course, it's the equilibrium magnetization. That gives you the biggest signal, and any contrast generated with MR is produced by reduction of that, so that's the limit here. And that's the parameter with which we can increase it. In reality, this is also an economic limit, making magnetic resonance of the 3 modalities the most expensive, because one has to build a very expensive magnet. That's the major cost factor in building the equipment. Image reconstruction. CT, SPECT, and PET, they are based on establishing the directionality of the photon. So for X-ray imaging for CT, you have the X-ray source, you have the detector, you have the collimator, the anti-scatter grid with the source, and that the detector, the directionality of the photon is determined. For SPECT, it's pure collimation, physical collimation with the collimator grids, and in PET, it's electronic collimation through coincidence detection. All 3 modalities have in common that the establishing the directionality of the photon is critical for image reconstruction. This leads to the radon transform, that the signal is acquired in the form of a radon transform, and a standard way of reconstructing is projection reconstruction. Magnetic resonance imaging, on the other hand, the detection of the signal is there, the precession of the magnetization under gradient. This precession time signal is then a frequency analysis done, and that's done through Fourier transformation. So the preferred image reconstruction for MRI is Fourier transformation, and in reality it's 2-dimensional Fourier transformation. So this is the main difference. Through this central slice theorem, these two are in essence linked, and it is actually true that some MR imaging modalities have started to use similar processes, similar ways of scanning the data like it's done for X-ray, but they still use Fourier transformation. And most of the X-ray data is still reconstructed with projection reconstruction. Contrast agents. So these are the molecules that are contrast modifiers. So they change the signal where they are in the tissue, in which voxel they are. If contrast agent is in a voxel, then the contrast agent is a molecule that changes the contrast or the signal. So in computed tomography or in X-ray, these are contrast agents are typically molecules that change the effective atomic number, so they are molecules with high effective Z. Iodine is the preferred, but not the only one, is a preferred agent here, so it's iodinated compounds. In magnetic resonance, the contrast modification is by shortening relaxation times. So whatever contrast agent in magnetic resonance that's being used, it always shortens the contrast. It always shortens the relaxation time. There's no way to prolong the relaxation time, be it T1, T2, or T2 star. So these are the major contrast agents. I won't include in this ultrasound in this comparison here, because we only dealt briefly with that. So we started out with the course at the beginning of the semester with the ideal imaging modality, and I introduced it to you. It exists in Hollywood. It's called the tricorder for those of you who are Star Trekkies, or you haven't, then you watch an episode of Star Trek. They always got these little devices that I can, if I point it like this, I can make a genetic analysis, your genetic makeup on this distance, and diagnose your disease and maybe even do DNA repair. That's how they made it up in Hollywood. That's the ideal imaging modality because it's portable, it's small, it's precise. I can diagnose your gene sequence on this distance. So I can go to any sick patient anywhere with a small device and do the diagnosis. And I don't have to get close. So this is the ideal technique. Okay? Outside of Hollywood, it does not exist. And so all of the imaging techniques that I've dealt in this course, and actually all imaging techniques, they have their pros and cons. So which one is right for you depends on what question are you asking. Be it a research question, be it a medical question, there is always somewhere when one decides to use a biomedical imaging technique, comes this process of reflection, of thinking, and asking the question, what do we want to know from the tissue? What are we interested in? And that defines what imaging technique you're most likely going to try out. And that's actually one of the hardest questions to answer in research and sometimes also in medical practice. So if one is interested in a rapid and least invasive assessment of tissue close to the surface, what technique would one use there? Rapid, least invasive. Well, we can think pregnancy. What technique do we use there? That would be ultrasound. It is rapid, it's immediately reconstructed, it's not very invasive, it's bedside. You just need some gel, the transducer, and you do the image. But if you've got bone or air in the field of view that you want to image, it's most likely prone to a lot of artifacts or even completely useless. So one has to know, is what I'm interested in imaging, is there bone or air interface in between? If there is, it's most likely going to produce some artifacts. If one is interested in contrast between air tissue or bone tissue and wants a high resolution scan that is very fast done, so here the imaging technique is X-ray or computed tomography. Okay, air tissue contrast, rapid scan. You've got pneumonia, you go to the doctor, what does the doctor do? A chest X-ray. How many of you have had pneumonia? Me too. All right, so you probably underwent some X-ray where they looked for the fluid accumulation in the lung. You want it to be rapid because you're not going to stick in an MR coughing like crazy because you're going to move. So it's the chest X-ray is the fastest. If you want to image receptors, glucose metabolism, transport mechanisms, perfusion. Receptors means high sensitivity. So here, the modalities of choice would be SPECT or positron emission tomography. So these are classic example is tumor. Patient has a tumor. Question is, does one want to do radiation treatment or chemotherapy? One question that comes in is, how many metastases have formed? There's too many metastases. There's no point in bothering the patient with a very invasive and perturbing therapy because you know it's pretty much hopeless at that point. Biochemical information on tissue. Here one would use an MR spectroscopy or an MR spectroscopy if was interested in doing the analysis. If one wants exquisite soft tissue contrast with millimeter or in rodents with 100 micron spatial resolution, soft tissue contrast, there the modality of interest is magnetic resonance imaging through the water signal primarily. The thing to consider is magnetic resonance depends on, the signal depends exquisitely on the molecular environment of the spins. We've seen that with relaxation, we've seen that with a chemical shift, and one thing to remember is if the spins are immobile, it's pointless to do an MRI. Okay, so I'll give you an example. We had a guy this looks like the transmission is back. Okay, so MRI, immobile spins are a no-go, bones are not good. Functional information, we have MRI. If we talk about brain function in particular, there is some functional information you can get with CT or with these other techniques, but MRI here is, in the meantime, is also the preferred technique. Certainly for neurosciences, that happened about 25 years ago. Here with MRI, because it's T2 star contrast for functional MRI, air-bone, air tissue interface, anything close to the air tissue interface is no good. So close to the ear canal or the sinuses, those areas are difficult to measure. Moving blood, angiography, so depicting blood vessels. Here you have with MRI, I gave you one example today with the face. There are multiple ways of measuring the blood flow in vessels, the transport of blood to the tissue. In computed tomography, it's possible with contrast agents, and in ultrasound with Doppler ultrasound, or also with the microbubbles, the contrast agents for ultrasound. The thing to bear in mind is the limitation for X-ray techniques is the number of scans that one can do. Okay. Computed tomography, SPECT or PET, is not the modality you want to go in as a volunteer every other week, no matter how much they pay you. Okay? On the other hand, with MRI, you can do that. But you don't want to go into an MRI if you have a metallic implant or some medical device in your body. And we've talked about when you visited the lab, examples are pacemakers, aneurysm stents, so metallic clips that solidify a blood vessel. Those are the absolute no-nos for going into an MRI scan. Very often it depends. For the teeth, in typical, it's okay. A screw in the bone usually is also okay. That really depends, but to think about here, it's stents from bypass operations in the heart or in the brain, pacemakers, insulin pumps, and so on. So these are the different imaging techniques. They all have their advantages and disadvantages. One really has to look at the catalog of things. There are, of course, imaging techniques that we haven't dealt with. This is photon imaging, so optical imaging. That's dealt with here on campus in the courses on biomicroscopy. We haven't dealt with electron microscopy. There you need vacuum, because you're dealing with electrons, and so forth. There are a number of these techniques that also there, depending on the question that one's asking, they might be the preferred technique to use. So let's look at some examples. The first example is from the brain. So we have for X-ray imaging, the skull is actually not so desired, because the skull is usually not the thing that one wants to image when one images the head. So the bone scatters the X-rays more, whereas MRI passes through the bone. So here, in this image, these images have been, by software, what one calls the process skull stripped. So whatever signal is non-brain has been removed from this image artificially. Okay, which one is what modality do you see on the left? MRI or CT? On the right, is it CT or MRI? Anybody dare an answer? Okay, who thinks on the left it's MRI? Who thinks it's CT? Okay, who thinks on the right-hand side it's MRI? Who thinks it's CT? Who thinks it's SPECT or PET? Okay, how can you tell on this image? Well, one way to tell is, in this case, the gray-white matter contrast, the soft tissue contrast, is worse on the CT image because the electron density is so close. So this one here is the CT image, and this is the MRI image. So here's another example. That's the MRI. This is the PET scan. Here's another MRI. This is from a human patient. This is T1 weighted. This is in a oops, this goes forward. This is T1 weighted image. This is T2 weighted image, and that's the corresponding PET scan. This is now a macaque, a monkey brain. Okay, here's another one. Top left, MRI or CT? MRI? No takers. CT? Some takers. Top right, MRI? No takers. CT? Okay. Bottom left. Is that an MRI? CT? On the bottom right, MRI? CT? Okay, you're good. Okay, now, how can you tell that? Well, one thing that you can see is they're fairly similar in the sense, again, that on the surface, now this is not skull stripped, the bone on the CT shows up bright, lots of electrons. The fat on the MRI shows up bright, lots of short T1 components. So it's a T1 weighted image. They have in common that on the left is a native image, so inside the brain, weak contrast for CT, strong, relatively strong contrast for MRI. And now on the right-hand side is the application after the contrast agent. So same image, before and after contrast agent, before and after. And here where you see the arrows, these are the ring-enhancing lesions. So these are ring-enhancing lesions in these patients. And that's the hallmark of cancer. At the edge of the cancer, the blood-brain barrier is being destroyed. That's where the cancer is aggressively destroying healthy tissue. So here's CT, MRI, pre and post contrast. Completely different contrast mechanisms, but in a way able to depict the same thing. So here's an example of high-grade astrocytoma. Different images. So we're looking here at the top left. Fat is bright. Exquisite soft tissue contrast. So what kind of imaging technique is that? T1 or T2 weighted or CT? Is this a T1 weighted image? Yes? No? Don't know? Yes? T2 weighted image, anyone? No? CT image? No. This is a T1 weighted image. Fat is bright, and this is post contrast. How about this image? What modality is that? Any guesses? Is this an MRI? Actually, could be. You could generate a contrast that looks similar, but I will tell you it's a fairly standard contrast. Is it a CT image? Yes? No? So what it is, what could it be? Yes? Diffusion weighted image. Yes, in the early days they looked like that. Now they're crispier. So, what has low spatial resolution? Because that's one thing that we see here, low spatial resolution. It's one of the emission computed tomography techniques, be it PET or SPECT. Bottom left. This has good soft tissue contrast, but you don't see much fat, so it's most likely MRI. But what type of MRI? T1 or T2 weighted? T2, any takers? T1, any takers? No? Okay, good. Here are the ventricles. Same area here. Signal is bright, so that is a T2 weighted image. What about this one? It's got stronger contrast. Is that T1 or T2 weighted? I hear T2. Everybody agrees? Yeah, so this is also T2. The difference between these two is the echo time. So here's T1, post contrast. This is MRI T2, two different echo times. And we have FDG PET. And this is all the same patient. So what do we learn from these four images? Ring-enhancing lesions, low glucose metabolism here, but high glucose metabolism at the edge. And there is changes in the T2 weighted image. Here is a FDG enhancing lesion. This is a disruption of blood-brain barrier in the post-contrast. And we have an increased T2 in this area. So what one can see is there is still a tumor there. Most of the neoplastic tissue, that is the cancer cells, they are here. They're not inside here, so that's the surprising part of the PET scan. There is in this image destruction of the tissue, so part of it is necrosis. But typical with a tumor, there's also edema, and in edema there's a change in water content and therefore T2. So these are the events that are here. Now, where would one want to do the radiotherapy? One would certainly not want to do the radiotherapy where there's necrosis, because there, necrosis by definition is already dead cells. So one will want to hit the tissue where the cancer cells are most active, and that would be here, most likely. Depends a bit on the tumor type, but that's where one would want to attack, even though by all the other techniques, the largest part of the lesion is somewhere else. Okay, let's compare some images of the body. On the left side is a whole body PET scan used for metastasis detection. On the right is the whole body MRI scan. And you can see there's a stronger contrast, soft tissue contrast, very strong anatomical contrast. This here is a different contrast. CT, 3D computed tomography of a mouse. One can see very nicely the skeleton. The soft tissue is less well depicted. Here's two images in the heart. On the top, an MRI image. So here's the blood. This is the muscle, the heart muscle. And here is the uptake of a SPECT agent in the heart, typically related to blood flow. Okay. Here's two images from the lung. Which one's the CT image? Okay, let me ask you this. Is this a CT image? Show of hands? Nobody? Is this an MRI? Okay, so those who didn't raise their hands, what is it? What do you think it is? How could you tell it's a CT image or an MRI image? Okay, you look for structures that correspond to bone. What do you see? The vertebra, and you see the rib cage here. So this is a CT scan. You don't see this as well. This is the MRI, the corresponding MRI of the lung here. And this is obviously some lesion inside the lung that shows up. Liver, this is ultrasound. Ultrasound is easy to spot because you typically have those radial streaking artifacts. And this is the MRI of the liver here. Typical for MRI are the blood vessels and the patchy appearance of the liver. Oops. So these are some comparisons of the imaging techniques, and that's really the last slide of this semester. You're going to have 4 more days of classes. With this, I will say goodbye, and well, I'll still be here for the exercise session. I hope you enjoyed this course. I know for some of you, I think you literally had the first course with me 5 years ago, some of you, right? It was Tuesday morning after the Jeune Fédéral. Yeah, about 5 years ago. Okay, so it's been a pleasure teaching you, having this class together. For some of you it's been 4 years, for some of you it's been just this course. I hope you'll have a great time with your master thesis, and maybe our paths will cross later on. Thank you very much.